Okay, so welcome back, everybody. I'm in my office, thankfully now. So let's try these Cahoots. Again, if you would like to participate, as for people who were attending on Monday, my laptop went into cardiac arrest when I tried to open up this Kahoot. So we're not going to do that anymore. And I think some of these, one reason is because I don't know how to change these settings, but instead of opening it up in Chrome, which I'm in, it will open it up in one of the other browsers. And one of those is Internet Explorer. And they're getting rid of Internet Explorer anyway. So, anyway, I guess, I don't know if that had something to do with it, but in any event, I'm going to put this in slideshow mode and try to open this up. And while we're waiting to do that, let me just stop that share and then reshare. Does anybody have any questions? Not at this point in time. If you do, just unmute yourself and pop in with a question. All right, let me change that share. Okay. All right, so we're going to give this a try. And I'm pretty sure, so you should see this kicking in. Okay, so I need to just get in there and then reshare it. See, it does this funny thing sometimes. So let me just keep playing with this a little bit. Yeah, up there it goes. Maybe it's just really slow. Can you see the pin?
No.
Okay, let me just quick break that share and then reshare it, because sometimes it works and sometimes it doesn't. There you go. Okay, is everybody in that wants to get in? All right. Okay, good. All right, so just something to keep in mind. Phalanges are the bones of your fingers and your toes. And even though they're small, they are long. They are longer than they are wide. Yeah, so just kind of keep that in mind. Usually you've had lab by now, but Nice. Okay, nicely done. All right, let's break that share so it doesn't freak out. Let me close those two out. Leave the page, go back to the PowerPoint. And we're going to go to the next one, or the one at the end of the lecture. There we go. There we go. Okay, is everybody in that wants to get in? Let's hope so. Okay. Nice. If you don't get this right, it's okay. I think this is preceding the one of the last, or maybe we did cover that. I don't remember. I don't remember now. Also traumatized when my computer shut down. I can't remember. I think we talked a little bit about osteoporosis and osteomalacia. All right, proliferation means going to increase the number. Okay. Okay, very good. All right, let me stop that share. I'll close those out. Okay, nicely done. All right, I need to close those out, those PowerPoints, and I need to open up a new one. So just bear with me. Go back into my thumb drive. Okay, we're continuing with the axial skeleton. Okay. Okay, so we have the skeleton has two major regions to it. Has the axial and appendicular. So the axial skeleton are the bones through the center. In this diagram, they're kind of that light blue color. They're the bones of the skull, and those bones within the ear itself. But we really look at those, in more detail when we get to special senses and we look at the ear anatomy. But it includes the vertebral column, right? Ending and including or ending with and including the sacrum and the coccyx. We have the sternum and the ribs, and the hyoid bone, which is actually found kind of below your chin, but above your voice box. So it includes the bones of the skull, the vertebral column, your hyoid bone, your thorax, which are your ribs and sternum, and the ear ossicles when we study those in special senses. So we start with the skull characteristics. Most of the bones of the skull are flat, but there are different markings and structures, that you have to be able to identify. Well, first we have things called sutures, and sutures are interlocking joints uniting skull bones to one another. When you develop embryologically, the bones of your skull, are separate little kind of, we call bone islands. And as they grow larger and larger, they ultimately come together and fuse down, connecting bone to bone. So those points where they fuse down, it looks kind of like a zigzaggy line, almost like a zipper that's zipped up. You see the kind of teeth of one bone kind of interdigitating with another. Those are our sutures, and they're held together with fibrous connective tissue. So we have sutures. We have sinuses, which are air-filled cavities in the cranial bones, lined with a mucous membrane that lightens the skull, warms and moistens air, adds resonance to your voice. There will be 4 that you're going to be able to recognize in lab, and in lecture, theoretically anyway. I don't give you images, but we have a frontal sinus, maxillary sinus, ethmoid spot sinus, sphenoid sinus, within the skull. Foramens are holes or openings in bone where nerves and or blood vessels pass through. A foramen is a rather discrete hole where you can see one side and clearly the other, so to speak. It's like a doorway. Once you go through it, it's not very thick, but you can see the inside versus the outside. And of course, like any door or window, it's for something to pass through it. Right? Fontanelles are areas of connective tissue between the cranial bones and the fetus that allow the skull to change shape through the birth canal and allows for brain growth. So where these bones will ultimately, as this infant matures some, is that these soft spots, what we call of the skull, these fontanelles, will become closed down and replaced by bone, and then all the bones of the skull will be fused with one another. So here we show the location of the sinuses. The sinuses are named for the bone in which they're found or where they're located. So we have a frontal bone to the forehead of the head. The sinus cavities there would be the frontal sinuses. We have maxillary bones, or the maxilla or maxillary bone is, the up, what can I say, how to explain this? Below the eyes, and also includes the upper part of your mouth where the upper row of teeth insert on. That's your maxillary bone. So the cavities within there would be the maxillary sinuses, and so forth and so on. We'll look at the ethmoid bone and look at the ethmoid sinus there, the sphenoid bone, the sphenoid sinus. Those are, deeper within the skull. Right. Then we have fontanelles, and those are these little soft spots on a fetal skull. We use the fetal skulls to identify these in lab. So you have the fontanelles that are right through the center, between the right and left sides of the skull. We have two of them. We have the anterior fontanelle found to the anterior aspect between the frontal bones and the parietal bones, and a posterior fontanelle that's found to the posterior aspect between the parietal bones and what's called the occipital bone. Right, so they're right in midline along the sagittal suture. And where these two pink parietal bones come together in this upper right hand, model that or picture that we're looking here of a skull, that will be your sagittal suture. If we look a sideways view or a lateral view, we also have more fontanelles. To the anterior and lateral aspect, right and left, we have what's called the anterolateral fontanelles. And to the posterior lateral aspect, to the back here, they call it the mastoid fontanelle, but we just refer to it as the posterior lateral. So to the posterior aspect, off to the sides lateral, or to the front, out to the lateral aspect. So that instead of referring to the sphenoidal fontanelle as the sphenoidal, we call it the anterolateral fontanelle, and the one that's labeled mastoid fontanelle in the back in lab usually referred to as the posterior or posterolateral fontanelle. Okay, so cranial bones. We have 8 cranial bones. We have 1 frontal bone, which is where your forehead is, and then above your ears we have 2 parietal bones. Or mirror images to one another, and then straight to the back behind that is the occipital bone, which is not only a portion of the posterior aspect of the skull, but the majority of the undersurface of the skull. We have 2 temporal bones. Essentially, your ear holes or your ears are on the temporal bone, and then we have an sphenoid bone and an ethmoid bone that are kind of deeper to those bones that are primarily on the surface of your skull or of cranium. The sphenoid bone is kind of found between the orbits of the eyes, although small portions of it do come to the surface of the orbit of the eye. So we're going to see a colored, a picture of a skull where all the different bones are different colors. And the ethmoid bone does the same thing. It has a small portion that kind of pops out superficially, to the surface, kind of in front of, anterior to your ears, but the majority of it is going to link together like the sphenoid does, the bones of the right side of the skull to the left side of the skull. So the frontal bone in the forehead region forms the anterior margin of the frontal lobes of the brain as well. So we not only call this the frontal bone, but when we look at the brain and we take the cerebrum, which is the outer region, of most of what you're looking at there. And it will be kind of divided into lobes, so that which is in contact with the frontal lobe and found anteriorly will be the frontal lobe of the brain. Forms the superior aspect of the orbits of the eye or your eye cavities and contains the frontal sinuses. The parietal bones are paired bones to the sides of the skull and kind of superior to your ears. There are 4 major sutures that connect essentially the parietal bone to the frontal bones in front, the parietal bones to the temporal bone inferior to it, the parietal bone to the occipital bone posteriorly, and then parietal bone to parietal bone. So the coronal suture is where the parietal bone meets the frontal bone anteriorly. The sagittal suture is where the 2 parietal bones meet in midline. The lambdoidal suture, I always say like a lambdoidal because that's the way you spell it, L-A-M-B, like a little lamb, D-O-I-D-A-L suture. That's where the parietal bone meets the occipital bone. It's kind of a rainbow shape, like a hoop. And then we have the squamous suture, where we find the parietal bone meets the temporal bone laterally. So this is, I highly suggest studying the bones if you're not familiar with them, and even if you are, is study them with these pictures of the skull where the bones are individual colors, because it really allows you to see the borders of them, and how large or small they are relative to bones adjacent to them. So here in the kind of magenta, reddish color are your parietal bones. Behind it in brown is the occipital bone. So that zigzaggy line fusing those 2 bones together is the lambdoidal suture. And then from the parietal bone to the temporal bone, where you can see the ear hole here called external auditory or acoustic meatus, that is your squamous suture that sutures together the parietal bone to the temporal bone. And then from the parietal bone to the frontal bone in front in kind of gold, there's your coronal suture. And then in a subsequent view, when we're looking down on the skull, then we will see how the 2 parietal bones fuse together. But while we're here, it allows you to identify the bones that we're going to be looking at that you need to know both in lecture and lab, and then search in certain features found on them. So the frontal bone here in gold, if you go look inferior to that, you see the hot pink bone. That's part of that sphenoid bone that will kind of pop up to the surface that I was describing, but it's mostly found kind of between your ears and a little anterior to that point. You can see the blue zygomatic bone, those are your cheekbones. Right? And then we have kind of the orange mandible, that's your lower jaw. Right? That contains some structures that you have to identify, as well as the bottom row of teeth. And then the upper row of teeth is contained in the maxilla bone, that's the purple bone there. The nasal bone is in the location of the nose, it's kind of a dark navy blue. And then within the orbits of the eye, we have a lacrimal bone here in green. And behind that, there's a little portion of your ethmoid bone that comes to the surface. Right. From the back view, we can have a better idea of the broadness and the large occipital bone here. And that lambdoidal suture is kind of, I said, like in a hoop, or think of a rainbow, the shape of a rainbow. And where the 2 parietal bones come together, that's our sagittal suture. Okay, the occipital bone, the most posterior wall of the skull and the undersurface or the base of the skull. There are 2 structures and functions of these that you need to know. One is called the foramen magnum. A foramen, again, is a hole or a passageway. So this large hole, foramen magnum being large, is the passageway for the spinal cord to pass from the structure it sort of originates from, called the medulla oblongata, and the spinal cord passes through that foramen magnum and then continues protected by the bones of the vertebral column. To the right and left and slightly anterior to that point are your occipital condyles. These are rounded projections, kind of like, if you saw a teacup and saucer, the teacup undersurface is round. It will sit in a saucer-like structure in, one of the first vertebrae, right? So the condyle is this rounded projection. It articulates with the first cervical vertebra, called atlas. All right. So if we look at the undersurface of the skull, the teeth are pointing, to your nose. So your nose, or anteriorly, is at the superior aspect of this image. And then all the brown bone there, the entire brown bone, that's your occipital bone. Big hole in the center is a foramen magnum for passageway of different structures through it. And then to the right and left, a little anterior toward your nose, are your occipital condyles. And they're nice and smooth, so they function in articulation. You're going to learn that these different terms mean something. Like a foramen, as I described before, is kind of a discrete hole. It may be big, it may be small, but you can see kind of from one side to another. Processes are extensions of bone, generally for the attachment either of a tendon, which attaches a muscle to bone, or a ligament that attaches bone to bone. And then smooth surfaces like the occipital condyles form articulations. So, that occipital condyle is going to form a joint or an articulation with another bone. And that's why there's smooth surfaces. You don't want rough surface on rough surface. You want smooth surfaces to reduce friction. Okay, then we go to the temporal bone. It's the inferior lateral bone of the skull. If you put your finger in your ear or your thumb in your ear and you kind of rotate your index finger around in a circle, that's where we find the temporal bone. Right. So the external auditory meatus or canal, right, is the external of this meatus. You have an internal and an external, but the outside surface, external, auditory for hearing. And meatus is a passageway or kind of a tunnel through tube. So this is a passageway for, of the ear canal, for the ear canal, to the middle and inner ear. The mastoid process is found posterior to a little inferior to that point. It's a roughened surface on both sides, on left and a right, and it's for the attachment of what's called the sternocleidomastoid muscle. And we'll learn the muscles, in the next chapter. But one of the insertion for one of those neck muscles is going to be the mastoid process. And then we have the zygomatic process, which is a portion of the temporal bone that extends toward your nose. It's a posterior part of the arch of the zygomatic arch, or your cheekbone, that forms an articulation with the temporal process on the zygomatic bone. All right, so I'm not exactly sure why this campus decided to identify these particular structures, because there are others that probably would be a little easier to understand the naming process. But when we look at the zygomatic bone, which is essentially your cheekbone, it forms, it fuses with multiple bones, in the anterior aspect of the face. And the portion of it, this process of bone from the zygomatic bone that needs to extend backward toward this portion of the temporal bone, so they fuse together and form your zygomatic arch. The portion on the temporal bone is called the zygomatic process, and the portion on the temporal bone is going to be called the the portion on the zygomatic bone is going to be called the temporal process, and the portion on the temporal bone is called the zygomatic process. But we'll see that in just a minute. Okay, so this picture is showing you essentially just the temporal bone. In the upper left-hand side, that's the bone in orange here. And now that we have a little better picture in front of us here, we see what the zygomatic arch looks like, right? So the portion from the temporal bone that extends anteriorly is the zygomatic process on the temporal bone. Shows you what the external acoustic meatus or auditory meatus is. And then behind that and a little inferior to it is this bump called the mastoid process. Okay, the sphenoid bone spans the middle portion of the inferior skull. As I said, parts of it come up to the surface. It was the hot pink little portion of bone that was on that first image that we had of the skull. And it spans, the left and right kind of middle region, little anterior, not exactly in the middle, but a little, anterior and superior to where your ears are. It has a scooped out region called the sella turcica, and that's where we find the pituitary gland. And we'll look at that pretty significantly when we get to AMP2 in the endocrine system. Also within that bone, there are some sinus cavities, and thus they're called the sphenoid sinus. The ethmoid bone is sort of a walnut-shaped bone, of a large walnut without a shell. And it's found between the orbits of the eye. Portion of it does come up to the surface, because when we're looking at that skull, and we said, okay, we're looking at the nasal bone, and we saw the maxilla bone that was in purple, and then we had this lacrimal bone in green, and then behind it was this little piece of the ethmoid bone that comes to the surface, in the orbits of the eye. But the majority of it is kind of embedded, and doesn't come up to the surface, but it kind of links together frontal bone to the maxillary bone. We have two structures to identify there. The little holes passing through it to the right and left of what's called the crista galli are the olfactory foramina. So they're little holes, and they are for the passageway of the olfactory nerve, which is going to be the first cranial nerve. The piece of bone that sticks up right in the center is called the crista galli, and that is for the attachment of the dura mater. The dura mater is the outer of three connective tissues that surround the brain, and this connective tissue, attaches to the crista galli so that the brain doesn't bounce around. To help secure the brain in its location, and protect it from injury. All right, so here, in the upper left-hand side, you have a skull, and they make a cut across it, in the transverse plane or horizontal plane. And now we're going to look down into the skull. So when we do, all right, you can see the superior surface of that brown bone in the center. That's your ethmoid bone. And further in front of that would be your nose. So the frontal bone is there in that gold kind of yellow color, right? That's where your nose would be. And then we have the orbits of the eye that you can't quite see, but it's below this kind of little humpy region here of the frontal bone. And then you have the ethmoid bone, the little portion of bone in the center that sticks up in, superiorly is the crista galli, and the little holes, right, to the left and right of that in what's called the cribriform plate are the olfactory foramina, holes for the passageway of the olfactory nerves. In hot pink here, spanning from side to side, is the sphenoid bone, right? And the scooped out region in the center here, that is the sella turcica. And that's where we find the pituitary gland. If we could look a little below where those olfactory foramina are located, we would see some other cavities in that ethmoid bone, and those would be the ethmoid sinuses. And then sort of anterior and inferior a little bit to that sella turcica would be about the location of the sphenoid sinuses. In lab, especially if you're in lab here, on the Gibbs campus, when we use the live skull, or no, not live skulls, but they were human skulls, real human skulls, when they've been cut in different planes, it allows you to see these sinus cavities really well. So those human skulls are generally used for identification of the sinus cavities. And then when we have the little fetal models, the fetus models that are generally in plastic, those we use to identify fontanelles. All right, the facial bones, of which we have 14, includes the mandible, the maxilla, the zygomatic nasal bones, lacrimal palatine, vomer, and inferior nasal concave. The ones you're going to generally what you're required to identify will be the mandible, the maxilla, the zygomatic nasal lacrimal, and possibly a palatine, depending. Perhaps the eCampus version of AMP1 might ask that. Okay, so the mandible, right, is your jaw. Right? It anchors the lower row of teeth. Right? It's the only skull bone that can move. Ding, ding, ding. Right? The mandibular condyles articulate with the temporal bone at the temporomandibular joint. So when, I'll point to that condylar region. Some instructors refer to it as a condylar process. Right? So that's why I put it as a backslash. That condylar, mandibular condyle is the smooth hinged portion of the mandible. Thus, it's nice and smooth. That's how it attaches to the rest of your skull at the temporal bone. And thus it functions as an articulation. The coronoid process is found anterior to that. It's a piece of bone that is thin, but is sort of the shape of the dorsal fin of a shark, I guess you could say. And that is for the insertion of the temporalis muscle. So it acts as a muscle attachment. And then the mental foramen are two small little passageways on the right and the left, of the bony prominence, the mental region, it's called, of your chin, which is found anteriorly. And those little holes, they're called mental foramen for the passage of cranial nerves. So here we're looking at a mandible. The left-hand side, upper left, shows you where the mandible is located relative to the rest of the skull. The hinge portion to the top, that is the mandibular condyle. And that's why, it's really not a process, because below that, the little bump is technically called the process in Latin and by most anatomists, because processes are bumps on bone where something attaches to. And clearly that portion of the mandible needs to be smooth, and it's going to articulate, in the a corresponding area on the temporal bone that forms a joint. So, it needs to be a smooth surface, not a bump. And so, but, a lot of anatomists and people who teach in human anatomy and physiology and writers and publishers of books decide to change the terms for things. So essentially, they can charge you for, more money for the next edition of their textbook. So in any event, that's what we're talking about. The mandibular condyle backslash process is for articulation. Now, anterior to it, you see that piece of bone that sticks up anteriorly, doesn't it look kind of like the dorsal fin of a shark? That's the coronoid process. Right? We have a coracoid process that's found on the scapula, but this is the coronoid. So we say the coronoid process is close to the nose, and that's for the insertion or attachment or muscle attachment. It's going to be the temporalis muscle. And then anteriorly, right, on both sides, you would find this little mental foramen. And all foramen function as a passageway because it's a hole. And there'll be cranial nerves that pass through there. All right, then we have the maxilla bone. That is the upper part of the mouth, forms the upper jaw and central portion of the face, including the hard palate for the upper row of teeth. So the majority of the roof of your mouth is this maxilla bone. Right? The most posterior aspect of it, becomes the palatine bone, it's called, but the majority of it is the maxilla. And it also forms part of the orbit of the eye. Below the orbit of the eye, there are going to be two little holes, and they're called the infraorbital foramen for the passageway of more nerves, cranial nerves. Infra means below, orbit referring to the orbit of the eye, and foramen being a little hole. So it's the hole below the orbit of the eye. Other facial bones are your zygomatic bones, or what we consider our cheekbones. Remember that the temporal process of the zygomatic bone is going to extend a little bit posteriorly so it can fuse with the zygomatic process of the temporal bone and thus completes the zygomatic arch. The other bone we have is the nasal bone that forms the bridge of the nose. Just know the bone. There's no particular feature on it you have to know. And the lacrimal bone is one of the first bones as you dip into the orbits of the eye, right and left. At the inferior aspect of it, there's a little hole or passageway, and that's for tears to drain from where they're secreted on the surface of your eyeball, and then through, this passageway and ultimately through a lacrimal system to the back of your throat. All right, so here we're looking anterior to posterior and anterior view. We can see the forehead bone, the frontal bone. We have the orbits of the eye where the different, you can see several, or a few, I should say, different bones that come together and fuse and form that orbit of the eye. You don't have to know which ones form it. It's just handy if the things are color coded to see where sphenoid bones, can be found, where your ethmoid bone can be found, where your lacrimal bone, the nasal bone, they all, the nasal bone doesn't contribute to the orbit of the eye, but you can clearly see it on the anterior aspect. Right, so you have to the right and left the zygomatic bones. You have the maxilla in light purple, and you have the mandible down below in kind of an orangey brown kind of a color. You can see on the maxilla, the infraorbital foramen, right? On the mandible, the mental foramen. And those are the ones you have to know. Okay, then we move on to vertebra. All right. The vertebra we have, are in a stack or in a column. They mostly have the same anatomy, regardless if they're a cervical, thoracic, or lumbar vertebra. Cervical means these are the bones that are found in the neck area. They're the first 7 in the stack, and we always count from superior to inferior, a numbering system from 1, 2, 3, 4, 5, 6, 7 of the cervical vertebra. So the first cervical vertebra would start on the undersurface of the skull, and then you count downward toward your tail. So the cervical region is in the neck, the thoracic region is in the middle of your back that have ribs attaching to them. And then the lumbar region is the bottom 5 that then articulate with your sacrum. So most of them have very common anatomy to them. They change shapes. And some vertebra, in some regions, you have some unique features in them, like in the cervical vertebra. But we're going to first kind of identify generally what's common to almost all of them. And virtually all of them have a body. Right? The body of the vertebra is found to the anterior aspect, and it bears most of the weight of everything above it. Between each body of each vertebra is an intervertebral disc. Remember, we said the intervertebral discs are composed of fibrocartilage. They may have vertebral foramen. Well, let me back up and just say they all have vertebral foramen, but some have transverse foramen. So the vertebral foramen is the hole in the center of this vertebra. That's rather large diameter, and that's where your spinal cord will pass through this entire column of vertebra and bones. Transverse foramen, as found in cervical vertebra only, are found in what's called the transverse processes. And this is for the passage of your vertebral artery and vein to pass through. So the body, its function is to articulate with the vertebra above and below and with the intervertebral discs. The foramen, they're holes, so it's always the passage of something. All right. We have processes, and processes are extensions of bone, not spicules, but types of bumps on bone that are generally a little narrower and sharper than a process, the process such as the mastoid process that we saw on the temporal bone. These are for, just like any other process or bump on bone, the attachment of something to it. It's either a muscle, technically the tendon of a muscle, or a ligament that attaches bone to bone. That's why it becomes a roughened surface, because things are pulling on their attachment points. Vertebrae have transverse processes that point laterally, or lateral projections. And the spinous process, of which we only have one, points posteriorly. So if you run your finger down the back of your spine, you can feel that bump, bump, bump. Those are the spinous processes. Transverse processes stick out laterally, for which you have a right and a left. But all these processes are for something to attach to. Between each vertebral body and between the vertebra are intervertebral discs composed of fibrocartilage. It's kind of like a brake pad between vertebrae. It acts as an articulation and allows movement of one segment of the vertebral column, or one vertebra, lets it move, have a certain amount of independent motion, so that it makes your spine very flexible. All right, so here we're looking at a very typical, what we call lumbar vertebra. All right, the large portion at the inferior aspect is the body, so it's a big, bony region, and it would have an intervertebral disc above and below it. So that functions as an articulation. The big hole in the center is the vertebral foramen. That's for the passageway of your spinal cord. To the right and left, you see those little processes to the right and left. Those are your transverse processes. And the single process that points posteriorly is the spinous process. All processes and bumps on bone are for the attachment of something to it. Maybe a muscle attachment or ligament attachment. And all foramen, or anything that is a passageway like that, a hole of some kind, a canal or a foramen or a meatus, are for something to pass through that tunnel or through that hole. So they act as passageways. The vertebral column has divisions to it, as I mentioned before. You have the cervical region, which includes the first 7 vertebra, C1, C2, C3, C4, C5, C6, C7. Then we have the thoracic region immediately below that, for which we have 12 vertebra, and therefore 12 pairs of ribs that will attach. Then we have the lumbar region, which is 5 vertebra, L1 through L5, which supports the lower back and has all kinds of muscles attaching to it. And then below that, we have the sacrum, that is generally 5 fused vertebrae together. It says it's immovable, but it actually does have a certain amount of movement. And the same with the coccyx. Those are the bottom 4, generally on the average 4 fused little vertebrae at the bottom. All right. So here we can see from an anterior to posterior view on the left-hand side, the numbering system of the cervical vertebra, C1, T2, 3, 4, 5. The thoracic vertebra, then the lumbar vertebra, and here, we see the sacrum and the coccyx. If we look at it laterally, you can see this kind of S-shaped curve to the spine, and that's a normal shape of the spine. It acts as kind of like a shock absorber when it's in that undulating kind of shape to it. And you can see the spinous processes that stick out posteriorly. You can see, at least on this one side, which would be the right side, the transverse processes. You can see the intervertebral discs between all the bodies of the vertebrae, so you see how large and profound they are. And then a lateral view of the sacrum and the coccyx. Okay, so the cervical vertebra, they're, and this stack of vertebrae are small at the top and get larger as you go down, because they have to hold up more weight, above them. The first and second cervical vertebrae have their own names to them because they're very uniquely shaped. So the first cervical vertebra is also known as Atlas, and in mythology, Atlas holds up the world. So the Atlas bone is sort of a ring bone. It's kind of flattened and in the shape of a ring or a tire almost. It technically lacks a body and spinous process. We have what's called anterior and posterior arches to it, but it does have transverse processes, and it has a big vertebral foramen in the center, and it has little transverse foramen in its transverse processes. So it allows for a lot of rotation back and forth, looking right and looking left. Allows the skull to sit on that bone and have a lot of movement. The vertebra below that is called axis or C2. And this bone starts to look a lot more similar to the other cervical vertebra, but it has a unique structure. This little finger-like projection of bone on the superior anterior aspect of C2 of axis called the dens or the odontoid process. And that is for the ring kind of bone of atlas to kind of pivot around. So again, allows atlas and subsequently the skull above it to have a lot of rotation, a lot of ability to rotate so you can look over your right shoulder, over your left shoulder. All right. So here we can see the shape of atlas C1 on the top. That's what I was trying to describe, maybe like a tire kind of a shape to it. It has transverse processes to the side, and if you could look down into it, there'd be holes or passageways in those transverse process called transverse foramen. Has a big hole in the center, thus that's where the dens or odontoid process of the vertebra below it, axis, extends up into. And we have ligaments that kind of wrap around that dens so that the first cervical vertebra doesn't slip and slide anywhere. All right. So that C2 is the next vertebra. The unique feature on it is the dens or odontoid process for articulation. And then it starts to very closely resemble other vertebrae. All right, the thoracic vertebra become larger and have some differences in its appearance. These spinous processes become longer and start to hang down inferiorly, kind of like the trunk of an elephant, like the trunk of an elephant. They have a body, they have transverse processes. They do not have transverse foramen, only cervical vertebra has transverse foramen. They have a vertebral foramen for the spinal cord and a spinous process. They articulate with ribs and restricted movement as a result of articulation of the ribs to the sternum. So what we're saying is that thoracic vertebra have some movement within them and a good amount of movement, but there's not a lot of bending, forward, we call forward flexion, extension, lateral flexion, rotation, because the ribs, that are traveling from the thoracic vertebra anteriorly to your sternum or to your breastbone don't allow a lot of movement there, but there's some movement. The cervical vertebra and the lumbar vertebra will have more movement. All right, so this is the region in green over here to the left of the thoracic vertebra, and the ones over to the right, you see two very typical thoracic vertebra. So to me, I feel like, look, if you're looking at a vertebra and it kind of looks like an elephant or a giraffe, when you're looking at their spinous processes, you're in the thoracic region. We don't ask you about the superior or inferior facets, but we do ask you about the spinous process, the transverse processes, the body, and the hole in the center, which would be the vertebral foramen. Okay, lumbar vertebra, the largest and the strongest because they support everything above it. So they become these great big massive kind of chubba-lubba vertebra, right? Their spinous processes and their transverse processes are kind of nubby and blunt. They kind of look like sawed-off shotguns. And therefore, they have the appearance of looking sort of like a moose. Right? So here to the left-hand side, we see the region of the lumbar vertebra. There, L1, L2, L3, L4, L5, 5 vertebrae. And now look at these large, substantial lumbar vertebrae. Look at that spinous process, right? It's not long and delicate and hanging down inferiorly like in a thoracic vertebra. It kind of looks like, very chunky and blunt. And so I think it looks kind of like a moose, right? So if you see a vertebra that looks like a moose, then it's at least a lumbar. Right, we have transverse processes, spinous process, body, and the hole in the center, the vertebral foramen. So do you see how most of these vertebrae have very common, they do have common points of an anatomy, with the exception really of C1. And then some regions like the cervical vertebra, okay, they have some extra foramen in the transverse processes. And when you really study the anatomy, there are some unique features, demifacets of the thoracic spine and mammary processes, on lumbar spine, but they basically have the same plan in anatomy. Okay, the sacrum is a triangular bone made of 5 fused vertebrae. That the fusion occurs between 16 and 18 about years of age and is complete by the age of 30 generally. Just a little FYI, they form a joint called the sacroiliac joints with each side of your pelvis. So this is how the appendicular skeleton is going to connect to the axial skeleton. The COCCYX, called the tailbone, are the last few 3 to 5, depending vertebra, that fuse together and form your tailbone. That's the shallow Hal bone. If you ever saw that movie, Shallow Hal. Right, so here we have the sacrum and then the COCCYX. There are other points of anatomy there. This campus, we don't generally identify a lot of them, so you just have to know, what is that bone? Sacrum. What are those bones? The COCCYX. Okay, the hyoid bone is the one found in the throat area, said below your jaw or mandible, but superior to your voice box. Does not articulate with any other bone. Oh, interesting. You should know that. Held in place by ligaments and muscles. Located between the mandible and the larynx. The larynx is your voice box area. And is an attachment site for different muscles for the tongue and the neck. And this is the shape of it. It's kind of a U-shaped. So does not articulate with any other bone. Okay, the sternum or your breastbone. It's a flat bone that articulates directly and or indirectly with the costal cartilages of ribs 1 through 10. All right, ribs 11 and 12 are going to be free floating on their own back there. Right? So 1 through 10 ribs either have their own attachment to the sternum via the costal cartilage, which of course is hyaline cartilage, which includes the first 7 ribs, and so they are then considered to be true ribs, and then all the ribs below that will be false ribs, but we'll get there in just a minute. All right, so the sternum has 3 parts to it: the manubrium most superiorly, then the body, which is the majority, and then the xiphoid process in the inferior aspect. The manubrium and the manubrium and the body function as articulations, and the xiphoid process is going to be for a muscle attachment, your rectus abdominis. Rectus abdominis also attaches to some of those costal cartilages down there, but that's what the xiphoid process is really for. Ribs, for which we have 12 pairs. The first ribs, and you number these the same way you did vertebra, from superior to inferior. So you just count down. Right? The superior, or the first 7 ribs, are called true ribs because they have their own independent costal cartilage attachment to the sternum. The bottom 5 ribs are called false ribs. They do not articulate directly to the sternum. And the most inferior of the 2 out of those 5 bottom pairs, or 5 false ribs, are free floating ribs. They don't have any anterior attachment. All right. So here we have a picture of the sternum. All right. So let's start there. Manubrium, body, xiphoid process. Then we have our ribs, and you can count 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Right. The first 7 ribs have their own attachment to the sternum, so they're considered true ribs. So over the left-hand side, it says true ribs 1 through 7. False ribs are 8 through 12. And the 2 pair 11 and 12 are free floating. They're still considered false ribs though. Okay, so that takes us to a cahoot. Let me boot this up and then I'll change my share. give it a moment to connect because it seems to be taking its little time. There we go. Okay, then let me change my share. There it is. Okay. Let's see, we can try changing the type of music. We can do 80s vibe. Let's try that. Huh. Interesting. Okay. So for those of you getting registered in there, we are going to try to get through the axial and appendicular skeleton. And that will be the end of the presentation. Now that you're kind of getting the knack of hearing some of these terms like processes and foramen and things like that, then the rest of this kind of moves a little more quickly for you. We will begin the muscular system next week. Okay, let's get started. Right, it's part of the appendicular skeleton. We just covered the axial. Did we look at the parts of the scapula? So it's part of the appendicular, so it's false. Yay, good. Nice. All right, take a good look at that. That's a good question. Very good. Getting closer. Yay. Good. All foramen, all holes are for the passageway of something through it. Very good. Okay, it's the mandible. I know that was tricky. Remember, students wrote these questions, not me. The mandible is the only skull bone that can move. Oh, remember we said the hyoid bone does not articulate with any bone. Nice. Good. Very good. Nice. All right, very good. All right, let me stop that share, close that down, and let me get into the other notes. So we'll get in the appendicular. Let me close these out. There we go. Okay. Okay. All right, let's just load that, let that load up for a second. It usually takes a little bit. So we're moving on to the appendicular skeleton now. So that's going to be the arm, the bones of the arms and the legs, and the bones that attach them to the axial skeleton. All right, so we have the pectoral girdle. Think, most people know what their pectoral muscles are. That's of the chest. The pectoral girdle, though, attaches the upper limb bones to the axial skeleton, and that includes the scapula and the clavicle. The clavicle is the bone anterior. You don't have to know any other features on it. Yes, there are some, but you just have to know that that bone is called the clavicle. The scapula is your shoulder blade and is found posteriorly. And the scapula and the clavicle will form a joint between the two of them. The features that you need to know is called the acromion, which articulates with the clavicle, so it functions as an articulation. The spine of the scapula, which is for the majority of the part of the scapula that you can palpate when you feel for and try to feel the borders of your scapula, and it serves as a muscle attachment. The coracoid process acts as a muscle attachment. Your pectoralis minor muscle is going to attach there. And then we have the glenoid cavity or glenoid fossa, indentation, a cavity. And this is for the articulation or for the humerus, your upper arm bone, to fit in and form a joint. So it's kind of like the head of the humerus is like a teacup and sitting in a saucer. And the saucer portion of it is the glenoid fossa or cavity. So here we're looking at the ribs, and we're looking at the right side of this individual of this skeleton. We have the clavicle anteriorly, and behind it is the scapula. The clavicle forms a joint with the acromion, or what's called the acromion process of the scapula, and that's your AC joint, your acromioclavicular joint. Below the clavicle, do you see this piece of bone that points out anteriorly? Well, you will see it when this rotates a little bit, because this is primarily trying to just show you the clavicle, but that's going to be your coracoid process. All right, so here we're looking at the scapula from posterior, so we're looking at the back of an individual. Right? We have the coracoid process on top. That does not articulate with anything. It just kind of points anteriorly. It's inferior to your clavicle, and that is a muscle attachment, specifically pectoralis minor. Then we have the acromion, which is the portion we just looked at that will form a joint with your clavicle. You have the spine of the scapula, which is this raised long ridge here for muscle attachment. And then to the lateral aspect, this is how your humerus will form a joint with the scapula. That is your glenoid cavity or glenoid fossa. If we look at it from lateral to medial, this is this indented region, kind of a saucer kind of a structure here for your humerus to fit into. You can also see the relationship of it with the coracoid process anteriorly, posterior and superior is the acromion, and where the spine would be located. Okay, then we move on to the extremity bones. So we're going to work our way out. We're on the humerus, and then we'll look at the forearm bones and bones of the wrist and of the fingers. The humerus is the longest and largest upper extremity bone. The anatomy that you have to know is the head. So that's that rounded portion, kind of looks like a tennis ball that articulates with the scapula. Thus, that shape of having a head like that gives your shoulder, the humerus, a lot of rotation and movement in that joint. You have the lesser tubercle that acts as a muscle attachment, the greater tubercle that acts as a muscle attachment. See, tubercles and tuberosities are all, types of bumps on bones, so they'll act as a muscle attachment. We need to identify our deltoid tuberosity, our medial epicondyle, which is another bump on bone, but on the medial aspect. We have the trochlea and the capitulum, which are the distal ends of the humerus that form articulations. So they're going to be a funky rounded surface, but they're going to be very smooth. So they function articulation. Right? The trochlea will articulate with the ulna and form a joint, and the capitulum articulates with the radius. But we'll look at that. And then the olecranon fossa is in the posterior aspect of the distal humerus. It's for part of your ulna to rotate into. It's a cavity area there. So it functions in articulation. Let me see if I have a picture. Okay, let's look at the picture before I move on to the forearm. Okay. So here we have the humerus. We have the head of the humerus. It kind of looks like a tennis ball with bumps on it. We are looking at the right humerus in anatomical position. All right. So the greater tubercle, the larger bump, is out laterally. The lesser tubercle is found anteriorly. Muscle attachment, muscle attachment. Midway down the diaphysis or shaft of the bone is the deltoid tuberosity out laterally. And that's for a muscle attachment. And try to guess what muscle attaches there. The deltoid muscle. Then we travel to the distal end, which of the humerus that will be in the area of your elbow. On the lateral aspect, we have the capitulum. It kind of looks like a little round ball. And medial to that, we have the trochlea. It's kind of a hump to hollow to hump region. That's for articulation with the ulna. And then to the medial aspect toward the ribs is going to be your medial epicondyle. And that's for muscle attachment as well. If we look at the back side of that humerus, at the distal end, that's what the olecranon fossa is. It's an indentation. And the olecranon that is found on the ulna will rotate into that. Okay, so let's go back up for the remaining upper extremity bones. We have the bones of the forearm, which are the radius and the ulna. The radius is the lateral of the two bones of the forearm in anatomical position on the thumb side, all right, on your thumb side. The feature we want is the radial tuberosity, which is at the proximal end, close to the ulna on the medial aspect, and that acts as a muscle attachment. That will be for the biceps brachii muscle, primarily. And then at the distal end, kind of found at the base of the thumb side of that bone, is the styloid process. The bones of the wrist include carpal bones, and then we have metacarpals and phalanges. Right? Carpal bones, we have 2 rows of 4 kind of squarish, unusually shaped bones. Then distal to that, you can, and if you make a fist with your hand, you can feel the long shafts of bone that terminate in your big knuckle ridge, right? If you have a fist, all right? Those are the metacarpals. And then beyond your big knuckle ridge are your phalanges, the smaller bones that are small but long, considered long bones. Each finger has 3 phalanges, the thumb only has 2. And in the toes, even the little toe, even though it's small, all your toes have 3 phalanges except your big toe that has 2. All right, so let's look at those. We have, here we're looking again, a right arm from the skeleton above. Right? We have the radius out laterally at the base of the thumb. Radial tuberosity, you have to know in red here, muscle attachment, and then the radial styloid process, or just the styloid process of the radius, maybe. No particular function for us. Then we add the ulna to the medial aspect of the forearm. So that'd be on the pinky side. We say PU, ulna, pinky to the ulna bone. We have the proximal end, which is called the olecranon. And the indented portion there, the scooped out portion, is called the trochlear notch. That trochlear notch pivots around the trochlea of the humerus on the medial aspect. And then at the distal end, we have a styloid process. Was that on the list of things you had to know up here? Hold on. Yep, a styloid process. So I really need to change that to red, I think, just so I'm consistent probably. But the ulnar styloid process, or the styloid process of the ulna. Now, while we're here, I want you to take a look at that interosseous membrane. That connective tissue layer keeps those bones approximated to one another so they don't split apart. That is going to be one of the joints we look at when we talk about articulations and joint classifications. How do we classify that? By the tissue that holds the 2 bones together, but we can also classify it by the amount of movement that occurs there. But this is a really good picture of the interosseous membrane. We have that membrane between the radius and the ulna, and in the lower extremity below the knee, between the tibia and the fibula. All right, then we have the bones of the wrist. Oh, before I go on there, let me just go back again. This shows you how the humerus and the radius and the ulna articulate with each other. So again, we're looking at the right arm, looking anterior, like you're looking right at someone's right arm. Right? You have the articular surfaces at the distal end of the humerus, the capitulum, and that sits in this kind of scooped out little region of the head of the radius. And then the trochlea, which is kind of a hump to hollow to hump region. It's like a spool of thread with no thread on it, if you can picture that, and if anybody still has spools of thread. And the ulna, or the trochlear notch, the scooped out portion of this olecranon, pivots around that trochlea. And then the last structure on the medial aspect from this view on the humerus is the medial epicondyle. If we look at the posterior view, you can see how that olecranon is going to rotate and slip into the fossa that's found on the posterior aspect of the humerus. Okay. Then we have the bones of the wrist and the fingers and the hand. The first 2 rows of 4 here, and you can palpate that on yourself, are these bumpy little bones there. Those are the carpal bones. And then the next row of longer bones are the metacarpals. And then distal to that are your phalanges. The little finger, the ring finger, the middle, the pinky finger, the ring finger, the middle finger, the index finger, all have 3 phalanges or phalanx. The thumb only has 2 phalanx or phalanges. You drive a car with your carpals, you walk on tar with your tarsals. Remind yourself that over and over again.
Ma'am, I have a question.
Sure.
Do we need to know the individual bones of the carpals, the scaphoid through the hamate?
Not if it's in the note. Nope. And in lab here, no one requires you to know them either, as far as I know. I mean, any of the full-time faculty, we don't. Good question. Now, if I think you should be finding now that, if it's not really in the notes, or maybe in a Kahoot Tootie quiz, or maybe a quiz online that, I don't ask. Okay, so now we're going to move down, go to the pelvis, and then the bones of the legs. The pelvic girdle is essentially each side of your hip or pelvis. So the whole pelvic girdle that's attaching the girdle, the part that attaches your legs to the axial skeleton at the sacrum, are called your coxal bones. You have a right and a left. There are 3 bones that come together and fuse to form each side of that pelvis or coxal bone, and they fuse anteriorly at the pubic symphysis. Thus, those bones are going to be pubic bones or pubis bones. And that pubic symphysis, remember, is fibrocartilage. Right, so anteriorly, it forms a joint of the pubic symphysis. Posteriorly, these bones will articulate with the sacrum at the sacroiliac joint. And essentially, it attaches the lower extremity bones to the axial skeleton. All right, so here we're looking at the entire pelvis, the sacrum and the coccyx in the center. So you have each side. It's composed of, so looking over at the left-hand side, you have the ilium, which is the majority of what you're looking at here. The pubis bone, which is the portion that extends anteriorly and forms the pubic symphysis. And then the ischium bone essentially is the bones that you're sitting on actually right now, called the sitting bones. And we'll look at the anatomy that you need to know there. So the coxal bones is composed of each side of the pelvis, an ilium, an ischium, and a pubis bones. Right, so those are the bone, 1, 2, and 3. The ilium is the largest and the most superior and posterior bone, arguably posterior, because the ischium sticks out posteriorly as well. But it's how the textbook describes it. It articulates with the sacrum to form the sacroiliac joint. The anatomy, or the point of anatomy you're to identify, is called the greater sciatic notch. It's a scooped out region, kind of looks like a question mark on the posterior aspect. And that is the only the only point of anatomy or structure of bone that acts like a passageway, but is not actually a hole. It's a scooped out region. Right? So let me try to rephrase that again. Virtually every other structure that you have to, whose function you have to know, if it functions as a passageway, it's a canal, it's a foramen. I mean, it's a hole through something. This is a scooped out region, a notched out region. But it does function as a passageway, and that's for your sciatic nerve. It's the longest nerve of your body. It's not a single nerve. It's actually from multiple lumbar nerve roots to come together and form one big bundle that then sends nerve branches off to all the different muscles of your lower extremity. Okay, then we have the ischium. It's a posterior bone and inferior. So if you're sitting there, if you roll back and forth, the bone you can sit, feel in your butt there that's making contact with the seat is your ischium bone. That point is called the ischial tuberosity. It functions as a muscle attachment. Your hamstring muscles will all originate from there. And then above that point, but inferior to the greater sciatic notch, is an ischial spine. A spine is kind of a sharper extension or finger, projection of bone. And that's for a muscle attachment as well. All right, then we go anterior and inferior, and we have the pubis bones. They come together to form the pubic symphysis. Thus, a symphysis is an articulation because we have fibrocartilage there. The scooped out region, that the femur will fit into, kind of like the glenoid fossa of the humerus. The acetabulum is for articulation with the head of the femur. And the only big hole through that coxal bone is called the obturator foramen. And so, of course, if it's a foramen, it's for passageway of nerves and blood vessels to pass through. So I find these pictures really helpful. This is one side of the pelvis, right? And when, again, they color code, then you get an idea of the size and the relative, anatomy that would be found on the ilium, which is the vanilla colored bone. Right? The pubis bone is anteriorly in that reddish kind of a color, and the ischium posteriorly is the purple bone. And you see how all three come together and fuse to form the acetabulum. That's the scooped out kind of cavity region for the head of the femur to fit into. All right, so back to the ilium. On the posterior aspect, that is your greater sciatic notch. Kind of looks like a question mark. Passage of the sciatic nerve. Below that, we get to the ischium bone or the ischial bone, and that little bump there, that's the ischial spine muscle attachment. Below that, that big roughened surface here, that's the ischial tuberosity, and it's large and it's rough because your hamstring muscles as a group, 3 muscles originate from there, and they are large muscles. They pull on those anchors, so it's a large roughened surface. And then the big hole there is the obturator foramen. To the most anterior aspect of the pubis bone, that is where, when the right and left pubis bones meet, would form the pubic symphysis. Okay, comparing a male and female pelvis. I personally don't ask questions like that, but you can, if you use what's called a pubic angle, you can very, very quickly, without getting thrown off, distinguish between a male and a female pelvis. They have some differences. In a female, that pubic arch, which is going to be the arch between the 2 pubic bones that come together, or the angle that's formed between the 2 pubic bones that come together to form the pubic symphysis. Right, the female pubic arch is larger and broader. The whole pelvic basin, it's called, when you look down into the pelvis, is wider and shallower. Thus it provides more space to accommodate the passage of the fetus. The sacrum is generally a little shorter and wider than, than the males. And the acetabulum face somewhat anteriorly. I find that is really difficult for you to really recognize, but the pubic arch is going to be the ding, ding, ding giveaway. The males, the pubic arch is smaller. The sacrum is generally longer and narrower. And the acetabulum are generally larger and face a little more laterally than a female's does. So when we look here, I think this lets you see this pubic arch, and you go, oh, that's the way to go, I think, if someone asks you to distinguish between a male and female pelvis. But so to the top row, we have, the diagrams or the pictures that show a male versus a female. The females is on the left, the male is on the right. Do you see where they have that little black arrow down there? That's the pubic arch. So in the females, you see how broad that is, and to the male on the right-hand side, how narrow that angle is. That's what they're talking about here. I think if you look at the acetabulum, you can't really see a whole lot of difference. The pelvic brim, what's called the pelvic outlet, that region between, the hole there, just anterior to the sacrum and posterior to the pubic symphysis, the shape of that, okay, there's definitely, the males is kind of narrower and more kind of vertical, so like square, where the females is oval. But look at that pubic arch, ding, ding, ding. That broad angle is a female, the narrow one, is a male. Okay. So the bones of the lower extremity, we have the femur. That is the largest bone of the body, the thigh bone. It articulates with the acetabulum. at the hip joint. And that articular region is called the head. It's kind of like the humerus, kind of looks like a tennis ball attached to some other bone. We have two bumps on the femurs. We have a lesser trochanter and greater trochanter. So trochanter means it's a large bone compared to the tuberosities, let's say the lesser and greater tubercles or tuberosities of the humerus. You know, they're rather small, but the femurs are big. So the greater trochanters are out laterally, and the lesser trochanters are found more medial and on the posterior or backside of the femur. When you follow from the lesser trochanter down toward the distal end of the bone, and especially in lab, you can actually palpate and feel this, is a raised line of bone called the linea aspera. And all those, the lesser, greater trochanters and the linea aspera, function as muscle attachments. Okay, then we have the patella, your kneecap. That's a sesamoid bone. It's embedded in the quadriceps tendon, helps protect the knee joint, maintains the tendon's position, but mostly is protecting that knee joint. Below the femur, we have the tibia, which is the bone that's found on the medial aspect in anatomical position. It's the largest of the two in the lower extremity because you have a tibia and a fibula. It articulates with the femur, so it carries the majority of the weight of the body. And so between the femur and the tibia are going to be those menisci that we identified, composed of fibrocartilage. Okay, there are 3 points of anatomy we want you to know. The tibial tuberosity, which is at the proximal anterior aspect of the tibia. It acts as a muscle attachment. This is where the family of quadricep muscles will commonly insert or attach on the tibia. So it's a very large rough area as well. From there, when you trace down the anterior aspect of your tibia, which is, your shin bone, you can feel, actually right now, you can palpate and you can feel that raised ridge of bone. If you ever whacked it on a piece of furniture, it's really painful because there's not a lot of fat or tissue between the skin and that part of the bone. That is the anterior crest. Acts as a muscle attachment as well. And lastly, the medial malleolus, which is on the medial distal aspect of the tibia, and that's for a muscle attachment as well. What you consider to be your inner ankle versus your outer ankle. All these different bones actually form, your ankle. But if you've ever, again, hit it on a piece of furniture, and they're also very easy to palpate. The medial malleolus versus the lateral malleolus. So the medial malleolus, these three structures are on the tibia. The fibula is a bone that's out laterally below the knee. And the only function or the only structure you have to know is the lateral malleolus. And that is the distal end. So I'll show you, where they are on a foot model. Then we have the bones of the foot. We have the tarsal bones as a group. Two specific ones we want you to know are the talus and the calcaneus. And then the rest of them can be just as a group. So it's sort of like the cervical vertebra. We said, this region is cervical. There's cervical vertebra. The first two are kind of special. So we want you to know the atlas and the axis. Well, in the ankle, we want you to know the talus and the calcaneus. The talus is on top of these two, and it articulates with the tibia. The calcaneus is your heel bone. And that is for the insertion of the Achilles tendon, or the common tendinous insertion of what's called gastrocnemius and your soleus muscle. The other bones of the foot have the longer shafts to them, thus called the metatarsals. And then distal to that are the phalanges. So similar arrangement as the hands. So now let's look at this. Here we have a femur. On the picture on the left side is looking at it anteriorly. So you have the head, which then points medially into the right side of your pelvis, into the acetabulum. And then you have the distal end down here. And yes, there are more points of anatomy on here. We don't make you know them. But on the left-hand side, we're looking at the same bone, but from the back side. All right, so again, you can see the head very well. And now you really can see the greater and lesser trochanters. I mean, you can see a good amount of the trochanter looking at it anteriorly, but I think you get a much better idea, not only once you go into lab and look at these bones. So hopefully some of you are actually looking at them and doing this face to face. But laterally and posteriorly is where you see the majority of the greater trochanter. And then inferior to that and medially is the lesser trochanter. The raised ridge of bone in the middle there, that is your linea aspera. The head functions as articulation because it's a nice smooth ball that fits into the acetabulum. And the trochanters and the linea aspera function as muscle attachments. Oh, and while we're here, over to the left-hand side, my bad, is the patella. What it looks like on the anterior aspect and the posterior aspect. Sesamoid bone. Okay, then we go to below the knee. The tibia is the large bone, the weight-bearing bone of the lower extremity. This is again on the right side. So the little pointy parts up at the top are called tibial eminences, and to the left and right of that are these flat surfaces that the femur sits on, and that's where you would find the menisci of the knee. All right, so then you, at the proximal end, you start working distally. You have this large bumpy region called the tibial tuberosity. If you trace down the anterior aspect of the tibia, you find another raised ridge of bone that you can actually palpate right now on yourself, as well as the tibial tuberosity. And that is your anterior crest or border. And then it terminates distally and on the medial aspect, so the inner thigh side is the medial malleolus. All right, so tibial tuberosity, anterior crest, medial malleolus, they're all muscle attachments. The fibula is on the lateral aspect. I call it the Q-tip bone because pretty much when you're looking at one of these, unless you're rather skilled, and well, you don't have to be that skilled, but you do have to kind of, look at it for a while. The both ends, or the proximal and distal end of the fibula, pretty much look the same. So I keep saying it looks like a Q-tip to me. The only feature on it you have to know for us is the distal end on the lateral aspect, and that is the lateral malleolus. And again, you can palpate that on yourself. If you've ever whacked that on a piece of furniture in the middle of the night, you know what I'm talking about. All right. Medial malleolus on the tibia, lateral malleolus on the fibula. And then look at that white material, that interosseous membrane here. That's similar, it's called the tibiofibular, or the tibiofibular interosseous membrane. The one in the forearm would be the radioulnar interosseous membrane. And we'll come back to that because that fibrous tissue there keeps those two bones together, and it's a type of joint. So we'll look at that in articulations. Then we can see the bones of the foot. We have the talus. So the talus is on top and articulates with the tibia. Your heel bone, the calcaneus. The other smaller squarish bones anterior to the talus and the calcaneus are just the other tarsal bones. And then you add the long shafts of bones distal to that. They're all the metatarsals. And that forms and essentially terminates on the balls of your foot. And then distal to that are your phalanges or your phalanx. You're looking at the big toe here, which is, that's where we have the first metatarsal. So we go first on the medial side and count 5 out laterally. You see only 2 bones, you're looking at the big toe. Everybody else is going to have 3 digits. Or 3 phalanx, I should say. All right, so here we can look at the whole knee joint, and the bones of the lower extremity and the bones of the feet. And that takes us to another Kahoot. Let me get in here and get this crack-a-lackin'. Oopsie doodle. Let me reshare. There we go. Let's try some different music. How about beatbox. I don't know if I've ever listened to that. All right, let's get started. Very good. You really could have used like 20 seconds for that one, but you know what articulates with something. All right, so it's your, the best is the radius or the ulna, and of course it's the radius. Good. Very good. Remember, this is pectoral girdle, meaning, so referring to the chest, or to the shoulders. Nice. Good. And more than likely, it's the ischial tuberosity that you can feel kind of between your butt and the seat. Nice. Very good. Right, because it's easy to confuse the coracoid process and the coronoid process. So that's why we keep saying the coronoid process is close to the nose, right? But the coracoid process is on the scapula. All right, very good. All right, nicely done. All right, let me close that out. And that one. All right. And let's just see. All right. I probably did not stop the share, so it might have locked up a little bit. Let me just show. All right. So does anybody have any questions? I'll give you an opportunity. Yep, and that is the end of the presentation. Questions at all?
I actually had a question. It's not really pertaining to the course, but I was just wondering if the interosseous membrane is damaged, would it regrow?
Not well, it would just scar tissue over generally, because fibrous connective tissue like that is generally avascular, you know, and you have to have a good vascular supply and tissue that can reproduce itself. But damage to that and a lot of inflammation there can produce what's called compartmental syndromes. Blah, it's hard to say. But when you get too much, you know, there's certain structures and vessels and nerves that are passing through there, and then you have muscles kind of surrounding it and bones to the left and to the right, you know, and so, you know, if you have an extraordinary swelling there, which is a medical emergency, compartment syndrome, is that you need to relieve the pressure in there. There's way too much either bleeding or inflammation and swelling in there, you know, but generally, no, not really. You know, a lot of those connective tissues, you might be able to scar tissue over a little bit and kind of band-aid it, just like, you know, tendons and ligaments are the same way. You know, they're connective tissue, they're dense regular connective tissue, and they don't heal well. I mean, you will slap some other fibers in there and kind of glue it together, but it will never be as good as before your injury.
Oh, okay, thank you.
Yeah, good, because why, were you thinking of Tiger Woods maybe?
No, I was just looking at the picture and I thought it looked pretty fragile, even though it's like inside of all the muscle and
Yeah, but surprisingly, it's quite strong, you know, because both below the knee and in the forearm, you have these two parallel bones, you know, and you know, there's not, especially for the fibula, I mean, it has these limited articulations at both ends, but you know, that's really about it. So you need to keep them kind of pulled together. Any other questions? Very good. Okay, well then, if you have a question over the weekend, you know, I'm around, just shoot me an email. Your quizzes will be due on Sunday. I will make sure that the exams are open for your review. If you find something that's a really bad boo-boo, just let me know. But I would say that I think most of them are going to be correct, the answers. So if you're going to email me about something, make sure you do your homework and check it out, because most of those answers come right from lab, you know, or from one of these Kahooty duties. And now, you know, when we prepare for the second exam, these Kahoot quizzes will be a good form of review. So, all right, then have a good weekend, and I will see you again on Monday.
Thank you.
Bye.
thank you. Have a nice weekend.
And you.